Hello and welcome back, everyone. Today we are going to speak about the estrogen as a part of six hormone clinical pharmacology. So we have several parts. We are going to speak about estrogen, anti-estrogen. We are going to speak about SERM, selective modify modulator receptor, and then we are going to speak about the progesterone and anti-progesterone or anti-progesterone. Okay, as I mentioned in the beginning, the estrogen will be the estrogen hormone as a part of clinical pharmacology will be part of the reproductive female hormones. You can see here from the list for the six hormone, they try to remind us with the three important hormones in human bodies. We have estrogen, then we have androgen, then we have progesterone. So three main hormones important for the human body produced from the gonads, could be from the ovary or could be from the testis. Number one, we have estrogen, following by androgen, then we have progesterone. These hormones very important for conception, for pregnancy, for embryonic maturation and development of primary and secondary characteristic during puberty. We could use this hormone for clinical use. Okay, you can see a lot of estrogen in the contraceptive, oral contraceptive or injectable contraceptive. We can use this hormone for management of menopausal symptoms, or for patients suffer from ovary deficiency, primary ovary deficiency, or like testis deficiency as replacement therapy. So we have three main uses of sex hormone: contraception, management of menopausal symptoms, and the third one will be replacement therapy as if we have primary hypogonadism or secondary hypogonadism. Sometimes we use antagonist hormone to treat some type of cancer. For example, we are going to discuss that with you later on. In general, in practice, we have three types of natural hormones. In practice, we have three type of natural hormones. We have estradiol, estrone, and estriol, and then they developed something called synthetic estrogen. And the main medication, the main drug in synthetic, we have ethinyl or ethinyl estradiol. Ethinyl estradiol, what is the advantages of this synthetic? So when we have something natural, what is the purpose of availability of synthetic? So we need to provide some advantages for compared with the natural. I prefer, for example, natural medication than the synthetic chemical medication, but we have some advantages provide from the synthetic chemical. We have ethinyl estradiol. They said it's less first pass metabolism, and that means we are going to have less dose to produce the same effect, and this available oral as oral medication. So two things. Number one is ethinyl estradiol provide less metabolism, less first pass metabolism, and number two is available like oral drug or oral presentation. Okay, we need to differentiate between the what type of estrogen, a natural estrogen we have in our body. We have estradiol, then we have estrone, then we have estriol. Estradiol normally produced from the ovary. Estradiol considered like the most potent estrogen in the female, and mainly produced during the age of young females. So you can see it here. We have three characteristic or three, yes, I prefer with the characteristic more than advantage. We have three characteristic of estradiol. Number one, produced during the young female age. Number one, most potent estrogen. Number three, mainly produced and secreted from the ovary. So we need to remember this for estradiol. Then we move to the estrone. Estrone is considered like metabolite of estradiol. And the potency, 1/3 potency of estradiol. It's not the same potency. The most potent one will be estradiol. Estrone, 1/3 of potency of estradiol, mainly produced during the menopause age, and This one responsible produced from the conversion of DHEA in the adipose tissue. So you can see here we have another type, but mainly produced during the menopause age. Moving to the last one, estriol. Estriol metabolite also of the estradiol, significantly less potent of estradiol. So this one very important, significantly less. Then we have this mainly estriol synthesized by the placenta during pregnancy. Now we have three organs responsible for the secretion, produce and secretion, three type of natural estrogen. The ovary responsible for estradiol and during the young female age. Then we have estrogen during the menopause and produced in the adipose tissue, 1/3 of potency. Then we have estriol produced from the placenta during pregnancy. And the question now, which of these natural estrogen considered like most potent? Estradiol, 1/3 of estradiol. Estrogen, the least potent estrogen will be estriol. Okay. This slide here represents the supervision of hypothalamus pituitary hormone over the gonads, over the ovary, over the testis. So you can see here the gonads, the hypothalamus produce the GnRH, stand for gonadotropin releasing hormone. And the GnRH stimulate the anterior pituitary loop to produce FSH and LH, which mean the follicle stimulated hormone and luteinizing hormone. When this hormone produced from anterior pituitary, this will lead to stimulate of ovary to produce two main type of hormone. Number one, progesterone, and number two, testosterone. As you can see here, is the first one from the ovary will be progesterone and testosterone. We don't have estradiol or estrogen directly. So then what happened there with the we have enzyme there, and this enzyme responsible for metabolism of estrogen or metabolism of sex hormone, and this cytochrome B450. Then we have another enzyme called aromatase. Aromatase, this enzyme responsible for metabolism or conversion of testosterone to the estradiol. So in females, we have testosterone, but at the same time, we have enzyme called aromatase in females. And this aromatase is responsible for conversion of testosterone to the estradiol. And then estradiol, this one, we discussed that with you. The estradiol will be responsible for the gene expression. We are going to discuss that with you because estradiol work on something called nuclear receptor and responsible for the RNA polymerase expression. Okay, gene expression. Here we talk about the nuclear receptor. We need to remember that this estradiol mainly produced from the ovary. And we have estrogen mainly produced during the menopause from adipose tissue. And we have estriol, this mainly produced from the placenta. So we have three types of estrogen, as you can see here in this graph. Moving to the next, this slide here, I would like to maybe share with you the website regarding the. So I prefer to review this one here, and you can see the fluctuation of hormone according to the, for example, starting with the anterior pituitary hormones, FSH, LH, then moving to the ovarian hormone, LH, estrogen, progesterone, and what happened to the endometrium here. And at the same time, we look on the ovary cycle, what happened to the growth follicles, ovulation, corpus luteum, and the remnant of corpus luteum. So I recommend you to review this website and read the information about this image, and maybe you can look on the code here or like abbreviation for the changes in hormone from the hypothalamus, pituitary, and ovary. Okay. So why this picture is important for us, as you can see here, this picture here or this image, this graph show us the site of action of medication. So we have medication. The medication will affect this axis, hypothalamus, pituitary, ovary. Important medication to remember, very important medication to remember. As you can see here, starting with the GnRH, antagonist. When you say antagonist, mean inhibit. When you say antagonist, mean this medication block the receptor. So GnRH antagonist block the hormone GnRH, gonadotropin releasing hormone. GnRH agonist practice maybe two model. Model number one, GnRH agonist, when you prescribe it in a balanced manner, will practice the stimulate the GnRH, and we use to treat infertility. So when you use agonist in balanced manner, we use for control stimulation of ovary and to treat infertility. But when you use GnRH in a continuous manner, continuous pattern, the result will be inhibit the hypothalamus, inhibit the GnRH. Moving to the next medication, we have clomiphene. Clomiphene here we have it in some maybe in other slides. Not only stimulate the pituitary gland, the clomiphene not only stimulate the pituitary gland, the clomiphene also stimulate the hypothalamus. So clomiphene stimulate the hypothalamus, clomiphene stimulate the pituitary gland. Therefore, we use clomiphene for the treatment of infertility for patients, for women suffer from infertility. Moving to the next group of medication, we have two main medications there. We have oral contraception, oral contraceptives, and we have danazole. As you can see here, oral contraceptive and danazole practice an inhibitory effect on the pituitary gland and inhibit produce of FSH and LH. So this is the reason that when you prescribe oral contraceptive or danazole, this will inhibit the release of pituitary hormone FSH, LH, and this will inhibit ovulation. Okay, moving to the next group of medication. Also here you can see danazole is repeated for the second time. We have ketoconazole, then we have danazole. Ketoconazole, danazole inhibit the enzyme responsible for metabolism of sex hormone. Okay, I will repeat that again. Ketoconazole, danazole inhibit the cytochrome B450. Ketoconazole, danazole inhibit metabolism of sex hormone and prevent formation of testosterone and androstenedione. Another medication, we have anastrozole. Anastrozole inhibit aromatase, could inhibit enzyme called aromatase. And this enzyme responsible for formation of estradiol, and normally you use it for patients suffer from endometrial cancer. Okay, moving to the next medication here on the list, we have fulvestrant. Also, fulvestrant inhibit the effect of estradiol. Fulvestrant consider like estrogen receptor antagonist. Estrogen receptor antagonist. Okay, fulvestrant. Then we have SERM, stand for selective estrogen modulators. So selective estrogen modulator could be practiced the effect of agonist or antagonist. We are going to discuss that with you. So this diagram here summarizes all the pharmacology treatment for the female hormones, specifically speaking about estrogen. We have GnRH agonist, GnRH antagonist, we have clomiphene, oral contraceptive, danazole, ketoconazole, anastrozole, fulvestrant, and SERM. Okay, here we're talking about the effect or action of the estrogen. Estrogen is very important for normal female reproductive development, for primary sexual characteristic, for secondary sexual characteristics. They found that estrogen decrease bone resorption and prevent of osteoporosis. This will prevent of osteoporosis. This is a positive and benefit of estrogen, prevent of osteoporosis. But the negative side from the estrogen increased risk of coagulability. That means estrogen increased risk of deep vein thrombosis and increased risk of stroke or clotting. For the estrogen increased plasma triglyceride. increase plasma triglyceride, but decrease LDL, and this is maybe advantages, and increase HDL. So we can say that estrogen has a positive effect on the lipid profile by the decreasing LDL and increasing HDL, but we have one negative side by increasing triglyceride. How this medication work, mechanism of action. Estrogen available in the plasma, binding to the proteins. So we have the estrogen in the plasma. We have estrogen in the plasma here, and estrogen bind to the protein in the plasma as estrogen P protein in the plasma. This is complex here, and then the estrogen will leave the protein, become free. So you can see here we have free estrogen. So what type of protein binding to the estrogen? We have globulin and we have albumin. So we have two type of protein could bind to the estrogen. We have globulin and albumin, as you can see here in this graph. So the complex here unable to move will be stay in the plasma, estrogen protein complex, but this equation is reversible. Then we are going to have free estrogen. The free estrogen will move between the cells, will move from the blood to the cells. So the free estrogen will leave the blood, the free estrogen leaving the blood, enter the cells, leaving the plasma, enter the cells, cross the cell membrane, and go to the nuclear receptor, binding to the nuclear receptor. So estrogen bind to the nuclear receptor, and the nuclear receptor now practice the effect on the RNA. So you can see it here. The activated steroid receptor complex interact with the nuclear receptor and responsible for RNA synthesis. And this will be responsible at the end stage on the responsible for physiological effect. Okay, so if I click on this graph here, only to share with you what happened on the level of nuclear, and this one published in the Journal of Clinical Investigation, and you can see here the estrogen enter the cells. After that, the estrogen enter the nucleus, and binding to the estrogen receptor affect the RNA and responsible for the gene transcription. We have other effect by the estrogen. This is the main mechanism of action. Enter the cell, enter the nucleus, binding to the nuclear receptor. We have another secondary effect by binding to the estrogen receptor on the cell surface and responsible for other effect. Okay, so speaking about natural estrogen, we need to remember we have estradiol, we have estrone, we have estriol. For synthetic estrogen, the main one, ethinyl estradiol, we have conjugated estrogen primarine, then we have diethyl stilbestrol, we have estrobibate. So this three medication or four medication here, ethinyl estradiol, conjugated estrogen, diethyl stilbestrol, estrobibate. I'm going to share the screen with you only to show you what we have for these products. Okay, I will start with the first one here. You can see here we have estradiol available like gel, or estradiol available like tablets. So estradiol. Then we move to the estrogen, ogen, and you can see the estrobibate. We have ogen, and then we have, if you move this one, remove it, ogen. Okay, then click again, and the image we have estrogen there. It's not very popular in clinical use if you speak about estrogen, estrone, and then we have estriol. Estriol available like cream. You can see it here. We have it like cream. Okay, if you click on this one here, they will take you to the image. This is the estradiol vaginal cream. Okay, then we move to the ethinyl estradiol, ethinyl estradiol. We have it here also, ethinyl estradiol. You can see it. It's like available as a tablet. Okay, we have primarine. This is a conjugated estrogen, primarine. conjugated. Okay, this is the Brimarine here, conjugated. Then we have diethyl stilbestrol. Stilbestrol considered like the carcinogenic medication. We don't recommend to use it in the practice due to the risk of cervical and vaginal cancer in the granddaughters. Estrobibate, also this one here, you can see it available like tablets. Okay, so again, we need to remember this information, these medications used in practice. Number one, natural estrogen. We have estradiol, estriol. We have synthetic estrogen. We have ethinyl estradiol or ethinyl estradiol, conjugated estrogen with Brimarine. Then we have diethyl stilbestrol. We have limitation, restrict for using because of the risk of cancer, cervical cancer or vaginal cancer. Then we have estrobibate. Okay, what are the clinical uses of estrogen? Estrogen mainly used as hormone replacement therapy. We are going to speak about that later on. Estrogen could be used for contraception and to prevent or treatment of osteoporosis. We have some article discuss the using of estrogen in patients from intractable dysmenorrhea, or we can use it for the patients from hirsutism and amenorrhea. And we have the asterisk here explain how this medication works. So what we need to remember, the main three clinical use: hormone replacement therapy, contraception, osteoporosis. Hormone replacement therapy due to the primary hypogonadism, premature ovarian failure, or postmenopausal hormone therapy. And then we have surgical removal of ovaries. So we have three cases. The patient may suffer from estrogen deficiency, and we have three cases. Could be primary hypogonadism, postmenopausal hormone therapy, surgical removal of ovary. Any benefit and risk? Okay, we are here talking about benefit and risk of estrogen. Estrogen were widely used in the prevention of osteoporosis. We like to use estrogen for osteoporosis, but the estrogen carry the risk of cancer. So, especially speaking about the endometrial cancer and breast cancer, due to the risk of estrogen therapy, we prefer to go with the bisphosphonates such as alendronate, risodronate, or zoledronate. So the first, maybe the appropriate treatment for osteoporosis, will go with the group of bisphosphonate rather than the estrogen, because estrogen carry the risk of cancer. We have two type of approach now. If the patient need the hormone replacement therapy, or if we need this hormone for contraceptives, the situation here in HRT and hormone replacement therapy, as I said, we are going to use estrogen with a lower potency. Okay, when you use estrogen and HRT with the lower potency, that means we have less side effect. Okay, with the contraception, we need to use estrogen with higher potency. Higher potency to inhibit the axis of the hypothalamus pituitary ovary. Therefore, the adverse effect within HRT will be less severe than the hormone used in contraception. So this may explain what happened there with the HRT versus hormone contraceptive. HRT we use lower potency estrogen, and contraceptive we use higher potency estrogen. Adverse effect will be lower in the HRT therapy comparing with the estrogen treatment and during contraception. Postmenopausal hormone, the main indication for the estrogen therapy in postmenopausal hormone is to treat menopausal symptoms. We have several slides to explain that, such as vasomotor instability, hot flashes, and vaginal atrophy. Here we have two different approach. If the woman has an intact uterus, we prefer, it's recommended, highly recommended to use estrogen plus estrogen. So we recommend to use progesterone plus estrogen to oppose the negative effect of estrogen. to oppose the effect of carcinogenic effect of estrogen. So if the woman suffer from postmenopausal symptoms like hot flashes, vaginal atrophy, and the woman still have the intact uterus, we recommend to use this combination treatment between the estrogen and progesterone to avoid the risk of carcinogenic effect associated with the estrogen. If the woman already removed the uterus by the hysterectomy process, the situation here, no need to oppose the action of estrogen. We use estrogen alone and no need to use progesterone. We are going to address this one in the flow chart later on. Okay, any risk now? Risk and recommendation. Yes, coming from hormone replacement therapy, there is a risk of cardiovascular event. There is a risk of deep vein thrombosis. There is a risk of breast cancer. There is a risk of endometrial cancer also. Okay, how we can avoid that? Use low effective dose. So start with low effective dose, short duration of action. Okay. Sometimes we try to use something like local, like vaginal estrogen cream instead of systemic estrogen to avoid. So we have it low. Try to use lower dose of effective estrogen, short duration of action, short duration necessary to relieve symptoms, and try to use local vaginal estrogen like cream rather than the systemic estrogen. Okay, so HRT and hormone replacement therapy, contraception. Contraception, normally we use this combination between estrogen and progesterone, and estrogen and progesterone normally produced like oral. This is a popular one. We have transdermal, then we have vaginal route, and we have other. We are going to discuss it later on, what type of oral contraceptive we can use it. The most popular oral, followed by transdermal, then we have vaginal route. Other therapeutic use of estrogen, we have primary hypogonadism, primary ovarian failure. We try to mimic the natural cycle. We try to prescribe estrogen and progesterone respectively according to the menstrual cycle. And the purpose of that, when we have primary hypogonadism, the purpose of that to stimulate development of secondary sex characteristic in young women. Okay, if we have deficiency in the hormone, we use it as a replacement therapy in the women suffer from hormone deficiency due to the surgical menopausal or premature ovarian failure. So we have several uses, and I will go back a little bit to remind everyone. We have number one, we have HRT. Okay, we have HRT contraception. We have the osteoporosis contraception. Could be primary hypogonadism, could be postmenopausal hormone therapy, could be surgical removal of ovary. Okay, case study here for a woman, 53-year-old woman, has severe vasomotor symptoms, severe hot flashes, and we have severe hot flashes associated with the menopause. She has no past medical history of surgical history. That means she has intact uterus, which would be the most appropriate to treat her symptoms. Shall we go with the conjugated estrogen cream? This one for the local, but this woman suffer from vasomotor systemic effect. This will not work for her. Estrogen transdermal patch. Okay, no, because this when you use estrogen, there is a risk of endometrial cancer and risk of breast cancer. We recommend for this woman here to go with the estradiol plus medroxyprogesterone, estradiol plus progesterone to provide the benefit of treatment of menopausal symptoms, at the same time prevent risk of cancer. There is no risk of cancer. Injectable medroxyprogesterone acetate is not enough for the hot flashes or severe hot flashes here. So the correct answer will be C, oral estradiol and medroxyprogesterone acetate. Regarding the medication, we have estradiol, ethinyl estradiol, and estradiol valerate. The estradiol valerate, when they prescribe it orally, this medication will convert to the estradiol and consider a prodrug. So estradiol valerate is a prodrug, will be metabolized to the estradiol. fat-soluble estrogen stored in the deposit show slow release and from the binding protein and from the pharmaceutical form, and this provide prolonged action compared with the higher and provide prolonged action, higher potency. So estradiol valerate, the comparison with the natural, number one, provide prolonged action. Number two, high potency compared with the natural. So we recommend to go with the estradiol valerate. We need to take in consideration drug-drug interaction or interaction with the antibiotic. Some important example here, the antibiotics sometimes accelerate metabolism of the estrogen and lower plasma level of estrogen, such as rifampin and tetracycline. And we know that this enzyme induced liver metabolism, and this will lead to the decreased estrogen level and may lead to the unintended pregnancy. So what happened here? Tetracycline rifampin accelerate metabolism of estrogen, decrease efficacy of estrogen, and this will lead to the unintended pregnancy. Adverse effect of estrogen. We have common adverse effect. We have nausea, breast tenderness. We have serious risk effect, or rare but serious. Could number one, we have thromboembolic event. We have myocardial infarction, breast cancer, endometrial cancer. So we need to remember these side effects or repeated adverse effect of estrogen therapy. Common adverse effect include nausea and breast tenderness. Serious side effect, increased risk of thromboembolic, myocardial infarction, breast cancer, and endometrial cancer. If we like to counteract or offset the effect of cancer of estrogen, we can combine estrogen with the progesterone to counteract to the effect of the estrogen. The estrogen causes uterine bleeding, and it's very popular side effect during the treatment in postmenopausal women. So we need to remember this one. Bleeding is like side effect of estrogen. So bleeding side effect of estrogen, because normally we use progesterone to treat uterine bleeding. Contraindication here, we don't recommend, speaking about contraindication, we don't recommend to use estrogen therapy in patients suffering from endometrial cancer, in patients suffering from history of breast cancer or genital bleeding, because this medication causes bleeding. And if the patients suffer from bleeding, we don't recommend to use it. If the patients suffer from liver disease, if the patient has any thromboembolic disease such as stroke, DVT, or pulmonary embolism, or like myocardial infarction. I will repeat that. For contraindication of estrogen therapy: endometrial cancer, breast cancer, genital bleeding, liver disease, or any thromboembolic disease such as stroke, myocardial infarction, deep-vein thrombosis, pulmonary embolism. Okay, this slide shows maybe the preparations available in the practice: ethinyl estradiol, macronized estradiol, estradiol subunate, estradiol valerate, and so on. You can treat it at your own time.